with non-invasive ventilation. So the objective of this talk would be to let you know when to use non-invasive ventilation, what are the choices we have, how do we use non-invasive ventilation, how do we initiate, monitor, wean, and when do we say failure, what do we do if the baby fails non-invasive ventilation, and then we'll look at how do we improve the efficacy of non-invasive ventilation, and what are the learning options which are available for all of us to learn more about this concept. So we'll start with this case. I would want people to put in the chat box if you have any special answers or queries so that I can discuss while you are going through this case. So here we have a 28-weeker, 1,002 grams girl child born by preterm labor. 1 dose of steroid was given 6 hours prior to delivery. So we know that this is an incomplete steroid coverage. The baby was born by C-section. There was no asphyxia. Baby had started having respiratory distress from birth, and he was shifted to a tertiary care NICU 4 hours after travel on nasal oxygen. So he comes to the NICU where respiratory distress is managed 4 hours after birth. And at admission to the tertiary NICU, the temperature is 36, so there is cold stress. Baby had severe respiratory distress, SA score of 7 by 10. The Silverman-Anderson score was 7 by 10. And the saturations were 93% on nasal oxygen, which looks like the baby is compensating a lot or working extremely high to maintain his saturations. So this is the baby which is the shown here. So you can see that upper chest, the chest above the mid-umbilical line and the mid-axillary line. So you can see the abdomen moving up, the chest is getting inside. There are some retractions below the mid-axillary line. There is some sternal retraction, and you can see the nasal flaring and the grunt you can all hear. So adding up, the score was about 7. The upper chest 2, lower chest 1, sternal 1, grunting 2, and nasal flaring 2. So upper chest is a chest above the mid-axillary line. Lower chest is a chest below the mid-axillary line. Xiphoid retractions and nasal flaring and grunting. You add up all the 5 components, you'll get the Silverman-Anderson score. So this baby Silverman-Anderson score was 7 by 10. So you have a preterm 28-weeker 1 kg with SA score of 7 by 10. So maybe you can write in the chat box, what will you do if you have a baby like this in the labor room? And so what will you do? What is that each one of you will do? Maybe few of you can write in the chat box so that I know that you are all attentive. He's maintaining saturation with nasal prongs, but he has increased work of breathing. Very good. Dr. Anindya, very good. So wonderful. So we would give CPAP support for this baby. Whether we'll give surfactant or not, we'll see later. But definitely this baby is an indication for surfactant. No, sorry, CPAP. So this is the X-ray of the baby. You can see that baby has classical RDS. The baby was on CPAP, started on CPAP, X-ray was taken. You can still see 6.5 spaces. There is reticuloglandularitis and low volume lungs. So what respiratory support you give for this newborn? What non-invasive support you give for this newborn? So some of you have already told me that it is CPAP you want to give. And how do you give? So do you want to give bubble CPAP, ventilator CPAP, flow driver CPAP? So which type of CPAP you want to give? You can write. Yeah. So yes, most people would prefer to give bubble CPAP because bubble CPAP is the most cost-effective way of giving respiratory support for this baby. But those people who have ventilator CPAP, they can give ventilator CPAP also. Or those people who have flow driver CPAP, they can use that also. So let's see how do we give CPAP for this baby and what do we monitor. So what non-invasive respiratory support? This is a preterm baby, less than 35 weeks. Silverman score is 28 weeks, so less than 35 weeks. Silverman score of 7 by 10. So this is called primary respiratory distress. That means the distress starts immediately after birth. And we're talking about support for primary respiratory distress. And so CPAP can be bubble CPAP, ventilator, or flow driver CPAP, and you can use any one of the interfaces. The other choice is nasal IMV. In some countries, they prefer nasal IMV over CPAP, but in India, we prefer bubble CPAP or CPAP over nasal IMV because it's simple to use, easy to monitor, and more cost effective. So all babies less than 35 weeks, or if you don't have gestation, less than 2 kg, and if the Silverman Anderson score is more than or equal to 3, immediately in the labor room, it is a candidate for CPAP. Now, some people may say that he has a severe distress, so you start on ventilation. No, even if the score is 9 by 10, baby has good respiratory efforts, you will give CPAP and not ventilation. So what do you need? How do we give CPAP? So for giving CPAP, you need a pressurized oxygen, pressurized air. You need a blender, you need a flow meter, and you need a servo humidifier. So the gases coming from the air and oxygen need to be blended, and then the gas are flowing into the circuit, and this gas should be warm and humidified before it goes to the patients. And you need a pressure generator, that is a bubble CPAP. In bubble CPAP, the pressure generator is the bubble chamber. So if you are using a ventilator CPAP, then the expiratory flow, the expiratory valve is the pressure generator. In bubble CPAP, bubble chamber is the pressure generator, whereas in bubble CPAP, it is the bubble chamber, and ventilator, it is the expiratory valve. So you can give CPAP with something like a Fisher and Paykel or Zeal or ventilator CPAP, and you can use any one of these 3 interfaces. You can use Hudson prongs, you can use a mask, or you can use a Ram's cannula. All 3 of them are good. So you can use any one, but among the machines, we would prefer to use bubble CPAP over the other CPAP because it is much more cost effective and much more easier to learn and do also. So how to give the support? We need to set up a bubble CPAP machine. We need to fix the interface. And once you set the machine and fix the interface, you need to know what are the knobs which we have on bubble CPAP and how do you adjust those knobs. So let us look at these knobs. So basically you have only 3 knobs in bubble CPAP: the flow knob, the pressure knob, and the FiO2 knob. So remember the rule of 5: flow of 5 liters, pressure of 5 centimeters, and FiO2 of 30%. So I will say a rule of 5 and 30%. Flow of 5 liters, pressure of 5 centimeters, and FiO2 30%. So if you are starting CPAP for a baby with respiratory distress, you would use these settings. But if you are starting CPAP for a baby with recurrent apneas, you will still use a flow of 5 liters. Pressure, you may use 4 centimeters, and FiO2, you can start with 21% oxygen. But if you're using CPAP for a baby post-extubation, so after extubation, you're converting the baby from ventilation to non-invasive. So there you can continue with the flow of 5 liters, pressure of 5 centimeters. FiO2, you continue whatever you were doing on the mechanical ventilation. So if you're extubating on an FiO2 25%, you'll use 25%. But if you're extubating on 30% FiO2, you'll extubate 30%. For primary respiratory distress, flow of 5 liters, pressure of 5 centimeter, FiO2 30%. This is what we'll start with. Now, subsequently, you can see here, you will start doing the flow adjustments. The flow is for the bubbles in the bubble chamber. So if the bubbles are present in the bubble chamber, that means your flow is adequate and there are no leaks in the circuit. The bubble should be something like this. Continuous flow of bubbles should be there for you to say that flow is adequate. If the flow is not adequate, first check for the leaks in the circuit. There are no leaks in the circuit. You can increase the flow from 5 to 6 or 6 to 7. More than 7 liters of flow is never needed for a baby on bubble CPAP. And when you want to increase the flow from 5 to 6, always check for leak before increasing flows. Now, the second is the pressure. We said we'd start with a pressure of 5 centimeters. Then look at the retractions of the baby or recessions of the baby. And the other method is to objectively do a Silverman-Anderson score. If your Silverman-Anderson score is improving, or it is improving, means that your pressure is working and your pressure is adequate. But if the Silverman score is same, Anderson score is same or increasing, that means your pressure is inadequate. Then you need to increase the CPAP settings from 5 to 6 or 6 to 7. So look at here. This baby was in a pressure of 5. You can still see that baby has significant upper chest retractions. There are sternal retractions. There are some lower chest retractions. So this baby's pressure needs to be increased. Now, after you take care of the retractions, that is after increasing the pressure to minimize retractions, later on, you need to look at the saturations, and if the saturations are between 90 to 95, your FiO2 is optimized. But if your saturation are less than 91%, then you to increase the FiO2. But if your saturation are more than 95%, then you decrease the FiO2. So first thing is to look at the flows. If the flows are adequate, bubbling is going to be good. Second, look at the retractions. If the retractions are still there, you keep increasing the pressure from 5 to 6, 6 to 7. And after optimizing the retractions or reducing the retractions, or after the SA score is falling, then you look at the saturations. If the saturations are between target range, nothing need to be done for FiO2. But if the saturations are less than 90%, 91%, you'll increase the FiO2. And if they're more than 95%, you'll decrease the FiO2. So if your saturations are less than 90% and baby has recessions, you keep increasing the CPAP pressure from 5 to 6, 6 to 7. So you keep the lung open. How do you know your lung open? By looking at retractions. If the retractions are minimal or not there, or your SS score is less than 3, you know that lung is well open and your pressure is adequate. So if there is hypoxia and retractions, you keep increasing the CPAP pressure from 5 to 6, 6 to 7 before going up on the oxygen. Now, if your saturation are less than 90 after improved retractions, that is if your SS score is less than 3, then still if saturation is less than 90%, keep increasing the FiO2 from 30 to 35% and 35 to 40, and in steps of 5 till your saturation comes to target range of 91 to 95%. So for hypoxia with retractions, our aim should be to keep increasing the pressures. And if there is hypoxia and retractions are minimal or SA is less than 3, keep increasing the FiO2 to maintain the saturation between 91 to 95%. Now, if your saturations are above 95%, then if there are no retractions, what will you do? First, come down on the FiO2. If you are an FiO2 of 50%, keep coming down 45, 40, 35 until 30. You come down in the FiO2 to 30% if your saturations are maintained between 91 to 95%. Once you come down to 30% FiO2, if there are no retractions, keep coming down the pressure from 7 to 6, 6 to 5. Once you are in a pressure of 5, FiO2 30%, then subsequently if there are no retractions and saturations are well maintained, then you keep coming down FiO2 25 and then to 21%, and then you decrease the pressure from 5 to 4. Once you're in a pressure of 4, 21 to 25% FiO2, you can remove the baby from CPAP. So in this baby, the baby infant was started on bubble CPAP with binasal Hudson prongs with a CPAP pressure of 5, FiO2 30% and a flow of 5 liters per minute. Over the next 24 hours, just with pressure and FiO2, you can see that the babies over the next 24 hours, the score of SAS have decreased from 7 to 3. Gradually, it came down to 7 to 3. The grunt disappeared immediately and the retraction started improving gradually over the next 24 hours. FiO2 remained at 30% because baby was maintaining same saturation of between 91 to 95%. And flows were kept at 5 liters because bubbles were always seen. And after that, from 24 to 36 hours, you can see that over the next 12 hours, the SS score further decreased from 3 to 1. And then FiO2 was decreased from 30 to 25%. And once the FiO2 came to 25%, then the pressure was decreased from 5 to 4 because there were no or minimal retractions. Flow was still kept as 5 liters per minute. So what will be the plan now? So along with titration of the pressures, what you can see here is when you're going up, you think of increasing the pressure. And when you're coming down, keep the lung open. So decrease FiO2 first and then come down on the pressure. So along with the pressure changes, FiO2 changes, the baby was also given caffeine because he was less than 1250 grams. And the baby was started on minimal enteral nutrition. That is, baby's mouth was coated with colostrum and tube feeds were started at 2 ml too early for this baby who is around 1 kg. So apart from doing CPAP, this baby was also started on nutrition and caffeine was also given because caffeine helps in improving lung condition, prevents BPD and prevents apnea of prematurity. So these are the other support things we normally do for babies on bubble CPAP and when they're preterm. The other thing is always whenever you put a when you put the nasal prongs, immediately put a orogastric tube and keep the tip of the tube above the level of the stomach. So this baby, since he came to pressure of 4, FiO2 25%, so there are two choices you have. If the baby is more than 1 kg, you can start the baby on HFNC, that is high flow nasal cannula. This is again a mode of non-invasive respiratory support. And if you're switching to HFNC, like this baby is more than 1, so this baby is a candidate for HFNC. You start with flow of 5 liters, same as that on CPAP. FiO to 25%, same as that on CPAP. And subsequently, if the baby is maintaining good saturation between 91 to 95%, keep coming down the flow from 5 to 4, 4 to 3, and 3 to 2. And then come down FiO2 from 25 to 21%. And make sure that the saturation is between 91 to 92%. Once the baby is on flow liters, 2 liters, and FiO2 21%, you can switch over to room air, especially because the baby is more than 1 kg. But if the baby is less than 1 kg, you continue the CPAP pressure on 4 till the FiO2 is dropped down to 21% from 25%. Once the baby is on 21, CPAP less than on 4, there are no apneas for 24-48 hours, then you can switch over the baby to room air. Sometimes the moment you switch the small babies less than 1 kg baby to room air, you may see recurrent apneas or worsening distress. And these babies may be on prolonged CPAP for lung growth and also for preventing the apneas and for improving the lung condition. So that is how the story of this baby ends. But let's look at the same baby in a different scenario. So let's take the same, but different presentation. So the baby 28 weeker, 1 kg, respiratory distress, Silverman score 7/10, comes to the NICU at 4 hours, and we start bubble CPAP for this baby with pressure of 5, FiO2 to 30%, and flow of 5 liters per minute. But what happened now is, over the next 4 hours, you see that the SAVI score, SA score still remained at 6/10. So it has come down by 7 to 6 because grunt disappeared, but baby still had audible grunt on the stethoscope. Other things remain the same and saturations were still borderline. So what do you do now? So suppose you start the baby on CPAP, SA score is still more than 3, consistently above 3, and baby is maintaining borderline saturation. So what will you do? What will you do? Saturation are less than 90% and SA score is still high. So what will you do? So wonderful. I think one answer we got, that is you can give a dose of surfactant by Ensure technique. What is the other thing you can do? Suppose in surfactant is not available for you. You're already in pressures of 5, FiO2 only 30%. So what will you do now? Retractions are there, hypoxia is there. Any answers? Caffeine is already added. Caffeine doesn't help in the retractions, but no, we are still on a pressure of 5 only. So keep increasing the pressure from 5 to 6, 6 to 7. So before you go for IMV or even you think of surfactant, you have a choice of increasing the pressure, because I said keep the lung open. And how do you know lung is open? Only when your retractions are coming down. So keep increasing the pressure from 5 to 6. Yes, correct. Increase CPAP pressure from 5 to 6, 6 to 7, and keeping FiO to 30%. So even on a pressure of 7, if the saturations are still less than 30% and 90%, then you increase FiO2 from 30 to 35, 35 to 40 till a maximum FiO2 of 60%. So this baby, initially the pressure was increased and later the FiO2 was increased in steps of 5% till a maximum pressure of 7 and FiO2 of 60%. But flow was maintained at 5 liters because bubbling was always seen. So if you have reached a maximum pressure of 7 and still a FiO2 of 60%, but baby continues to have these retractions and maintains borderline saturation. So what will you do next? What will you do next? So baby is on maximum pressure. No, you can do many more things before going for ventilation. Ventilation is the last choice, Avinash. So this is a second scenario we're talking about, since you need to see whether you are giving correct CPAP or not. How do you know? There should not be any leaks in the circuit. That means there should be bubbles should be seen in the bubble chamber. And the pressure in the circuit should reach the lung. So for how do you know that? You should hear for the bubble sounds in the chest. If bubbles are seen, the pressure is there in the circuit. If bubbles are heard in the chest, the pressure is reaching the lung. And then you check for humidification appropriateness. That means there should be no condensation in the inspiratory limb. There should be some mist in the expiratory limb. and the temperature display on the humidifier should be 37 degrees. And check for the interface whether the interface is snugly fitting but not abutting on the nose, and the baby is not crying because of nasal injury. So clean the nostrils, put a saline drops, ensure that the prongs are adequately sealed and placed. So then you can repeat an X-rays to see whether the lung inflation is all right or not, or whether it is RDS or some other disease which you are seeing now. And there should not be any pneumothorax. So one can also do a 2D echo to see if there is an accompanied PPHN in this baby. So all these things were done. He is already on a pressure of 7 with FiO to 60%. Still retractions are there. Still hypoxia is there. There is circuit pressure is all right. Bubbles are seen. Circuit pressure is reaching the lungs. Bubbles are heard. Humidification is appropriate. X-ray is showing typical RDS pattern. There is reticuloglanarity. There is air bronchogram and low volume lungs. So obviously now you will give surfactant by Ensure technique. So if you have already given, you may give a second dose of surfactant before you think of shifting to ventilation or shifting for a higher center. So since the baby is very early in life, you can think of giving a second dose of surfactant if already given. If you're not given, you can give the first dose of surfactant now. So the baby was given Ensure and baby was continued on CPAP. And other supportive care was also taken care of. Baby's pain was relieved. He was cocooned, nested. Temperature control was taken. Mouth was coated with colostrum. Some feed, enteral feeds of 2 ml too early was given. And temperature was maintained between 36 to 37 on the skin. Baby's sugar was maintained. Hypoglycemia, hypocalcemia was ruled out. And the PCV was done, which was in the normal range of 45 to 60 in this baby. There was no polycythemia, and fluid management was taken care of. The baby's blood pressure was well maintained. Hemodynamics were maintained, and a fluid bolus could be given if there is suspected hypovolemia. So before you think that CPAP has not worked, one, you see that you're giving it properly or not, and then take care of supportive care. And after this, over the next 12 hours, you can see that SA score has come down. The baby was maintaining saturation of 90% and on FiO2 of 60% and pressure of 7. You can continue to do CPAP for this baby now, or since the baby continues to have a SA score more than 3 even now, then you have a choice now. What do you do now? You've already given 2 doses of surfactant. Baby continues to have retraction, is maintaining borderline saturation, and you're taken care of all the supportive care, and you know that the CPAP is being delivered to the lungs. So what do you do now? There is no PPHN. So there was no setting for infection also, because there was no PPRM or maternal fever or any other thing suggesting an infection. Otherwise, you could have given antibiotic also if there was a setting for infection and you have RDS. And definitely there was no cardiac disease in this baby, because 2D was shown no cardiac disease and no PPHN also. So what do you do now? 2 doses of surfactant, baby is on high setting, FiO2 to 60%. So some of you have given the answer previously. Maybe you can give the answer now. So one choice is ventilation, but we know that apart from ventilation, there are many other ways of taking care of this baby now. So the second dose of surfactant can be given or continue to look at this. But if after all this, if he continues to require high CPAP pressure and high FiO2 and saturation less than 90, you can think of NIMV, nasal invasive ventilation, and not ventilation. You can use nasal IMV, same prongs, same circuit. You shift from bubble to ventilator and do a nasal IMV for this baby. And nasal IMV can prevent CPAP failure or decrease the need for ventilation. So this is called rescue mode of support for failed CPAP is nasal IMV. The commonest indication for nasal IMV is rescue CPAP. So the settings of nasal IMV are exactly like IMV settings. So you start with a PEEP of 5 or 6 because you had 7 PEEP on the ventilator. On the bubble CPAP, you can start 5 or 6. Then, so you can give a pressure of 16 to 18. You can add 10 plus to the PEEP. You will get the PAP. TI you keep 0.4 second, rate of 40, flows of 6 to 8 liters, and FiO2 of 60% on the ventilator in nasal IMV mode. And subsequently, you can titrate the PEEP on the ventilator using retractions. If retractions are there, keep increasing the PEEP. And if the chest rise is there, your pressure is all right. The other method to look at PIP is all right or not is to auscultate it and see. If you are able to hear a good breath sound, that is this sort of sound is heard, that means your PIP is also all right on the nasal IMV. And SpO2, you titrate the FiO2 based on the SpO2 target of 91 to 95%. So we have seen how a CPAP can be given. We have seen if CPAP is not working well, how do you increase the pressure, how do you increase the FiO2, keep adding surfactant. Still, if things don't work out, if CPAP fails, you can think of nasal IMV. And if nasal IMV fails, then you can think of ventilation. But otherwise, this is the sequence one follows. HFNC can be used, especially if the baby is more than 1 kg. You are weaning from CPAP or you are weaning from nasal IMV, you can think of HFNC as a mode of ventilation. So these are the three modes of non-invasive ventilations, that is CPAP, HFNC, and nasal IMV. So just to summarize, CPAP is the primary respiratory support for infant respiratory distress, recurrent apneas, and post-extubation. Nasal IMV is mostly used as a primary mode if you have facilities existing, but I would prefer bubble CPAP over nasal IMV. Nasal IMV we often use as a rescue or for failed CPAP. HFNC for more than 1 kg we can use after CPAP or after nasal IMV, and it can be an alternative for from ventilation. If you're removing the baby, then you can use nasal IMV post-extubation. So how do we improve the efficacy of CPAP or bubble CPAP? For this, you need to know that the mask, the interface is a very important component. You can use a mask or a Ram's cannula or a Hudson prong, and your machine should be appropriate. That means there should be blended air, oxygen, compressed oxygen, servo humidifier should be available. There should be good humidification. That means the temperature should be 37. There should not be any condensation in inspiratory limb. You need to monitor the baby, the interface, and the machine, and simplify the setting. Rule of 5 and 30% FiO2 for starting. And recessions, keep increasing the pressures. And if recessions are not there, hypoxia is there, keep increasing the FiO2. Maximum pressure 7, maximum FiO2 60%. And always know the troubleshoot and use of adjuvants like caffeine, feeding, and keeping the feeding tube above the level of the tummy. All these are very good practices to improve the efficacy of CPAP. And always have a backup ventilation, or you should be ready for referral if the baby fails CPAP. So any one of the three interfaces, whether Rams or Hudson or mask, all three are good. We find all of them are good. We use mask for less than 1 kg. Normally, routinely, we use Ram's cannula for all babies for all the nasal IMV, but we used to use Hudson prongs. They are also very good. But logistics wise, ease of use, Ram's cannula is easier, especially for more than 1 kg babies. So you need a good CPAP machine. That means you need compressed air source, compressed oxygen source, a good blender, a flow meter, a good humidifier, which servo humidifier with inbuilt heater wire and temperature probe, and a pressure generator, a bubble chamber. Suppose you don't have a compressed air and oxygen, you can use only cylinder oxygen. Then you need some device. I have some disclaimer here. This is the device which we made, and this has an inbuilt compressor. You don't need compressed air source. You need only cylinder oxygen. You can have a compressed air source. This has a compressor in it and it has a blender in it. You can also set the flow meter. You can measure how much pressure you are giving to the baby and how much FiO2 you give to the baby. You can titrate by changing the oxygen concentration, which is inputted to this device of Merck's Precise Air Oxy Flow. So, but if you want to convert this to CPAP, you need to have again a good humidifier and a bubble chamber. So in the absence of compressed air source and oxygen, you can use a cylinder oxygen, but you will need a Merck's Precise Air Oxygen, which has an inbuilt compressor, inbuilt blender, and it has a pressure and FiO2 monitoring. You titrate the FiO2 by increasing the oxygen inlet from the cylinder, and you can titrate the pressure by the bubble chamber, and you can titrate the flows using the flow meter. So the other method to improve the efficacy of bubble CPAP is using kangaroo care. So always gel kangaroo care with bubble CPAP to improve the outcomes, especially babies when they become stable. So you need to monitor, and the monitoring chart should have patient chart, that is heart rate, respiratory rate, retraction, Silverman-Anderson score, urine output, CPAP, how much you are giving. Then you also need to have the interface monitoring. There should be a gap between the columella and the interface. You should look at the nasal skin, whether it's getting blanched, and you should look at the column, it is not getting snubbed, and you should ensure that the interface of the tubing is not dragging the nose. And you look at the machine and if bubbles are seen or not, water in the bubble chamber level is adequate or not, water in the humidifier chamber is good or not, and whether water in the humidifier chamber is distilled water or not. So this is a simple CPAP poster which can be there in all SNQs so that you can know when to start, how to start for what setting, how do you titrate the pressures, FiO2 and flows, what will you do if there is a troubleshoot. So this is how you start for preterm respiratory distress, for recurrent apneas and post-extubation, adjustments, monitoring what you need to do, weaning and failure. So these are some troubleshoots. So if the baby is having hypoxia and retractions, what does it mean? Lungs are stiff. Lungs are stiff or the pressure is not reaching the lung. So how do you know the pressure is not reaching the lung? If bubbles are not there, there is a leak in the circuit. If bubbles are there, pressure is there in the circuit, but it's not reaching the lung, then there could be a nose block. If bubble sounds are heard, bubbles are seen, but retractions are still there, and baby is having hypoxia, that means your pressure is inadequate. So keep increasing the pressure or use surfactant to open the lungs. There is hypoxia, no retraction. That means saturations are low, lungs are open. So what does it mean? And you can look at air entry. So air entry is good. That means the pressure is reaching the lung. Bubbling is seen. So pressure is there in the circuit. So pressure there in the circuit, pressure is reaching the lung. So lungs are open, but baby has hypoxia. The problem could be that it is non-lung disease. That means there could be heart disease or a PPHM or a blender malfunction. So you have said 50%, but the blender is giving only 21%. So you need to cross-check the blender. If there is hypoxia and severe retractions, air entry is poor, bubbling is not seen, very simple that the pressure is not there in the circuit, definitely there is a leak in the circuit or your flows are inadequate. There is condensation in the inspirate limb, that your humidification is not appropriate. So you need to decrease, you need to increase the room temperature. You should ensure that the heater wire is working, the temperature probe is all right, and the end of the heater wire in the inspirate limb is not below the radiant warmer or it is covered with an opaque thing. The last part of the heater inspirate limb should be inside a radiant warmer or incubator to prevent condensation. There should be some mist in the expirate limb. If there is no mist in the expirate limb, either there is no water in the humidifier chamber or the temperature, room temperature is more than 37. So these are the things which you can easily correct. So this is a simple audit tool I'll share with Akash. So all of you can have this tool and see how you are doing CPAP in your unit. And you can look at individual baby and see. So the numbers here tell you individual baby. You can go through the baby, write the notes of the baby or make a checklist and see all your things about CPAP are appropriate for the baby or not. So the other